Laparoscopic appendectomy for uncomplicated appendicitis. The patient is positioned supine. The surgical team stand on the left side of the patient, surgeon towards foot end and assistant towards head end of the patient. The monitor is on the right side of the patient, around the middle of the body. The cables are attached to the right side of the patient near the right shoulder, and during the operations, patient's foot end and right side are kept up, that is lifted, so that the intestinal loose fall to the left and towards head end and keep the operating area accessible and visible easily. Common instruments are 5 mm telescope. I use 30-degree, Maryland forceps, Babcock, needle holder, scissors, bipolar and unipolar, suction apparatus, and keep ready, not in the main trolley, 10 mm port, 10 mm telescope and reduction sleeve if necessary, so that we can use. Cables are camera head with this cord, light cord, insufflation tube, bipolar and unipolar cords, suction tube, and keep in hand drain tube, 50 cc syringe, condom to be used as bag if necessary, and suture materials, and also normal saline ready at hand. Ports usually we use by 3 conventional ports. First port is by open technique at supraumbilical reach by vertical incision, and these are the 3 ports at supraumbilical reach, second at medial to left anterior superior iliac spine about 2.5 to 3 centimeter medial, and third is just above the pubic symphysis, little to the right of the midline. Here you can see
the port placement here, 3 ports. This, in case of smaller children, I would have given here. This here. So I am given it in a higher position. Okay. So
And I have a question to ask.
yeah.
That third port, you put it for us here in Cuba. We used to put it in the mud bonnet point. That third working port.
Oh no port in the McBurney's point. It is supraumbilical, suprapubic. You
Yeah,
can
for
see
us.
this is the pubis, just suprapubic, a bit right to the midline, just few millimeters to the right of the midline, not in the McBurney's point. No brightness common now. port at supraumbilical ridge, first port, that is camera port. A longitudinal incision has been given, blunt dissection to expose the linea alba, and then facing the sharp edge of the blade towards foot and stab. Just stab, checking with the tip of the mosquito forceps that it has entered into the peritoneal cavity. So now, after lifting the abdominal wall, first port is given, gas is attached. It is 12-year-old girl, so gas pressure is 12 millimeter mercury and flow is 2.5. Using all 5 ports, assuming it is uncomplicated. In case of complicated appendicitis, usually umbilical port we may use 10 millimeter, but it is presumably uncomplicated case, so 5 Two further ports are usually always 5 So now we are going inside and see what, yeah, you can see the adhesions. You see longitudinal adhesions from here, here, up to ascending colon, and near right colic flexure up to, and the bladder is empty. We have ensured it before bringing the case to the operation. It is a female child. We are giving this left-sided port a bit location to be in the bikini line, and the first port is given. Second port, sorry. The big tubercle. And we will just at the start of our journey, we will check the pelvic cavity. If the pelvic organs are normal, এটা তো আসছে. So we will look into the pelvic cavity first, then we will proceed for appendectomy, and if necessary we may নিচে যাও. এটা তো বামে দেখাচ্ছ, এখানে দেখাও. You see the appendix, uterus is very small, but 12-year-old girl, it could have been bigger uterus. Somehow it is very rudimentary, and the appendix, you see, appendix is distended with, you see, fecal matter, right? Indentations are there, so it is chronic appendicitis, and near tip it is angry looking. So what we will do is skeletonization, because we have used 5 port at the umbilicus. So if we do not do adequate skeletonization, it will be difficult to bring out through that port side without extending the skin incision, skin and fascial incision. So we will try to skeletonize as close to the abdomen, appendix wall as possible. And before completing this dissection, we'll burn somewhat here. You see some form of tenting, just pulling the ascending colon up. I want to release that to some extent to avoid future relative impediment to the peristaltic movement through this segment, so that the patient does not experience pain. So I always do not do this adhesive, but in this case I think it is necessary. You can see that this is elevated. I do this first before skeletonization because sometimes, as that is our principal goal to do appendectomy, after appendectomy I may forget about this. That's why I am doing it before the completion of the appendix. Try to keep as much away as possible from the intestinal loops, that is from colonic loops here, so that you do not injure them. This is something I think we need division of this part, so that I think it is okay. Jafrul or Kanchan, whoever. I cannot see properly. Okay, so okay, so I think the adhesive lysis is complete. Now we will scale the appendix. Be done in. So it is justified to do appendectomy in this case, right? You see the distension. Divide the major appendix, then go parallel to the appendix so that you do not perforate the appendix. You see, close to the appendix wall, but outside the appendix lumen. Keep the hook in this way, parallel. Okay, we can hold the appendix here. We need some bipolar diaphragm in here, otherwise there will be bleeding and it will cost you few more minutes. I do not want to do that. So I think we are here, right? This is the dilatation starts here. We can like it here. Do not need to be over enthusiastic to dissect close to the cecum. So the thread you need take is also not so long, because a long thread will give some difficulty during handling. You see the thread is around 6 inches, that is. So it is a bit long also, but you can take a shorter. And before not tying, I am squeezing at the junction of the appendix with cecum. Okay, so in this way you will hold this end, the long end, this way. Okay, the seal curvature is downward, the curvature of the concavity of the needle holder upward, so you can easily make the C loop. Try to ligate as close to, in fact, flush with the cecum so that there is no chance of future stump appendicitis. Okay. So this is a case of uncomplicated appendicitis. Occasionally seeing these cases, this type of cases, what to do in usual cases. Because most of the appendicitis are uncomplicated, right? So you have to be a master of doing uncomplicated appendicitis. Sometimes there are complicated, those cases you may not always be able to open. But if you can follow my techniques, no case of appendicitis usually needs laparotomy, except there is old case of perforation, lump formation in such a way that there is dense adhesion of the intestinal loops with each other. In those cases, you may need to open, otherwise not. And while you see, I have milked the content from the basal part, dividing part of the wall of the appendix, not the whole wall, keeping the posterior the part on the opposite side to help me traction. Now coagulating the stump, then we will divide and bring out the because in this way it will not come into the port lumen. We will straighten this way. You see? Now, if we try, it may enter into the port and it will come along with the port. But principal job is done. We will now removing the gas by removing the valves from the ports and little compression of the on the abdominal wall will expel all the gases, and then we will close the ports. First the umbilical port, because the patient is under spinal anesthesia. The action of the spinal anesthesia may wane, so we want to close that first because we need partial closure at okay. Morning.